Welcome back, everyone. We are getting ready for our final session of the day, but just make sure you don't log off when they're done because we're going to bring on our other Conquering CHD co-founder, Ms. Amy Baskin, for a great wrap up of the day and next steps. Let me just pull up these slides and get them ready for you all. All right, while we are waiting for our moderator to join us, I wanted to give a quick shout out and introduction to our panelists. This session is called Moving from Protocol to Person, Addressing Cultural Differences in CHD Care Management. Dr. Nemhard is the director of the Arkansas Center for Birth Defects Research and Prevention, as well as a professor of pediatrics in the Division of Neonatology at the University of Arkansas College of Medicine. She also serves on Conquering CHD's Scientific Advisory Committee. Dr. Adrian Kovacs is a psychologist and director of behavioral cardiovascular care at the Knight Cardiovascular Institute in Portland, Oregon. She is also a well-respected researcher in psychology and CHD. Before joining the team at OHSU, she was at the Peter Monk Cardiac Center in Toronto, one of the world's oldest and largest adult congenital heart disease programs. Dr. Swati Kondori is a medical science liaison with Cheesy USA, Inc. She is also the parent of 2 children, one who passed away from CHD. Dr. Kondori is an active volunteer with Conquering CHD Ohio and is passionate about mentoring high school and young college students interested in science. Swati is a passionate advocate for bereaved families with Conquering CHD and her family foundation. Dr. Nicholas Madsen is a pediatric cardiologist and the medical director of the Heart Institute at Cincinnati Children's Hospital. He is also the past chair of Conquering CHD's Scientific Advisory Committee. Dr. Madsen is a passionate advocate and enjoys his time at Camp Joyful Hearts each summer. Dr. Madsen is an assistant professor of pediatrics at University of Cincinnati, and his research focuses on improving outcomes for those living with CHD. Dr. Erica Sood is a clinical psychologist in the Division of Pediatric Behavioral Health at Nemours Children's Health System in Wilmington, Delaware. Dr. Sood is also the director of the Nemours Cardiac Learning and Early Learning Program, otherwise known as LEAD, in addition to her involvement with the Cardiac Neurodevelopmental Outcomes Collaborative. Dr. Andrew Van Bergen is a pediatric cardiologist and critical care physician at Advocate Children's Heart Institute in Oaklawn, Illinois. Dr. Van Bergen is passionate about continuity of care for his patients and ensuring their families receive the education and support necessary to make the most of the CHD journey. And lastly, we have Mr. Ken Woodhouse, who is an adult living with CHD. He lives in the greater Chicago, Illinois area and works full-time in philanthropy. As an active advocate, Ken uses his voice in the CHD and LGBTQ communities. Mr. Woodhouse is also an avid chorus singer and cyclist. Let's see if we have Dr. Nemhard. I think she's trying to log on. So I'm going to deputize, as someone said earlier, Dr. Madsen to take over and start the panel, please.
That sounds great. Good to see everyone here this afternoon. It has been, I think, a tremendous session so far, and I know all the panelists and I hope to continue that great trend. I think just really insightful sort of comments from a lot of our clinical experts, but a lot of, I think, really great lived experience and I think sort of, a sharing of knowledge that we haven't always brought to some of these conversations. And so thanks so much to everyone who has been part of the panelists so far. And with this session, we'll try to complement the themes that have been shared so far, but I think, obviously trying to add something additional. And that additional part is really the sort of element of culture and how culture plays a role in how care is delivered, both culture in the traditional sense and maybe sort of a consideration of medical culture and some of the elements of medical culture that I think that inform our everyday care practices and certainly the experiences of our patients and families. I think first question we'll start with, we'll go to Adrian. Adrian, there was a comment as we met and prepared, where I think many of us felt this way, and it really resonated that, we sort of felt like we were doing pretty well, and that that we were, as we thought we were being thoughtful relative to some of these themes, and I think like many of us, our eyes have really been opened. Can you talk a little bit about how this, sort of the momentum of the discussion over the last year plus has informed some of your care delivery? Reflect a little bit on, what we all thought was going well, or where we were being purposeful, but maybe not as anywhere near as successful as we aimed to be.
Yeah, sure. Happy to be here. I think I like that you use the word momentum, because I think that's what there has been a lot of momentum in the past year. And in one of the earlier sessions, Dr. Veronica Gunn used the term enlightened. And I think, like many people, I would have described myself as being very enlightened. And I think there's many of us who would have said, well, I'm not racist, I'm not sexist, I'm not homophobic or transphobic. And I think that what we've learned in the past year is that that's not nearly enough, and that approach really misses the mark for several reasons. So one is that it completely ignores the implicit biases that we all have. And there was a panel discussion about that earlier today that was very powerful. And so it ignores the fact that we are, first of all, not as perfect as we like to think we are. Secondly, it really dismisses all of the collective experiences that people have had up to that point that they present in front of you. So they may have experienced racism, sexism, discrimination, harassment, assault, violence, all of this history that they bring to us that we just don't know about. And I think clinically, and whatever our role is on the clinical team, so physician, nurse, psychologist, people bring their experiences to the table, and we don't know their backstory. So we don't know everything that has happened before then, and they may choose to share some information with us, but we don't know the whole story. And what's interesting is, again, in the past year, I think many people are realizing that not only that they themselves have faced or have had really negative experiences, but there's this sense of watching the news and vicariously feeling part of a group that has been discriminated against. And so I think that if we don't acknowledge the fact that although we might think that we provide a safe environment, they may not have had safe environments in all of their previous healthcare encounters. And then I think the third thing is, if we have that approach where I'm kind of good enough at this, it puts that burden of trust on the patient instead of us. And sometimes, in the media lately, we hear about, well, how do we get this group to trust us? And I think it's not up to patients to trust us. It's our responsibility to behave and communicate in a way that earns their trust. So we need to figure out how we do that. So how do we create a welcoming environment that allows people, that allows patients, families to know that it's okay to disclose information to us, that we care about them as a whole person. We want to know about the totality of their experiences. And I think what's unique in the congenital heart disease world is that, as physicians and nurses and traditional members of the team, it's been easy to focus on their heart. That's mostly why they're in front of you. And even as a psychologist, so I've always been for the past 15 years, been fully embedded within cardiovascular teams. So it's even easier, historically, it's been easier for me as a psychologist to focus on the cardiac elements that have contributed to psychological distress. And that is, in doing so, we're not quite providing comprehensive care, because many times it may not be the first visit, but it may be a little bit down the road that people disclose that they've had some pretty negative traumatic experiences both outside and inside the healthcare system also. So I guess just to summarize, it goes beyond saying, you know, I'm pretty good at this. And I think that anybody in the past year, any healthcare professional who hasn't sat back and thought, yikes, I need to do a lot better, I'd kind of be disappointed in that. I'll pause there.
Thanks, Adrian. So you talked a little bit about some of that experience from the patient and family point of view. Swati, I'll go to you next, and you know, you obviously I think met some of these cultural challenges head on, both, you know, sort of at the patient level, but certainly thinking sort of more broadly about the U.S. healthcare system. Can you talk a little bit about that experience and what that insight has provided you, and maybe, you know, again, you know, shedding more light on some of these blind spots within our system and our care models?
Sure. Thank you, Dr. Madsen, for that great question. But honestly, thank you, Conquering CHD, for having us, and for it's a privilege to be with all of you, and especially this esteemed panelists. So I'm glad to be a part of it. Coming to your question, Dr. Madsen, my husband and I did our education here. I came here for my doctorate, and shortly after that, we had our first son, and then our second son, Kanan, was diagnosed much postnatally with hypertrophic cardiomyopathy. And as I always say, ironically, I was doing my research in the same field. But when we got admitted into the hospital, as much as I thought that I understood, because I was in a school of medicine and everything, there was such a distinction in the care that is provided in the US healthcare. We both are from India, and the way the system it was there, that I had a pediatrician when I was growing up, and if I had anything health defect, I would go to my pediatrician, who would then refer me to the cardiologist, and that person became my main person if that was the main defect. So in my son's case, I was referred to, we never could go to the pediatrician because Kanan was, once I delivered Kanan, he was quickly moved to the Children's Hospital, and we didn't understand what was going on. We thought, okay, we're going to meet, we didn't even know what was the diagnosis. This was postnatally 8 weeks that we got to know he was diagnosed with cardiomyopathy. But in the beginning weeks, we couldn't understand what was going on because there was no prenatal diagnosis. So I've delivered my son, and I'm excited, but at the same time now he's in the NICU, and I have no idea who to contact. And I'm not able to understand, because in my mind, I'm thinking that I'm going to have my pediatrician call me, or I'm thinking there is going to be someone who's going to walk in. But the next thing I know is, you know, grappling between my C-section pains, the hormonal, issues, and another 3-year-old who didn't understand that he's just become a brother, but now my mom and dad are all in the hospital. So there's this constant juggling, and that them not understanding the system, that the way it works is they're attending and the specialist walks in when there's an issue. So I had no one to consult or ask any questions, which was not the case when I was back home. So I could call up my pediatrician and say, hey, what's going on? Who should I contact? So my husband and I do not have family here. So they were back home. So, you know, we're just thrown into this situation, trying to understand what is going on, trying to, swim through this really fast things that are evolving with Kanan. And it was a hard situation. So the first 4 weeks was just trying to understand there was something wrong, and then trying to understand what are we supposed to do? We came from a system where we don't question authority. So we're not asking the doctors that great questions or anything. And my husband stayed in the hospital every single day. So he was slowly getting to understand the system. And then he started, advocating for our son and advocating for saying that how I understood this, the science behind it. So that slowly started to change. But that initial thing of, after 6 or 7 weeks, we found ourselves, we were finally able to, when we got out of the hospital, we understood, oh, this is how the system works, which was too late because there was a lot of things going on. When we were admitted again with Kanan the second time, this was for a much longer time, we found another Indian family, and my husband met them in the break room, and they were having the same issue. They were not able to understand this. They were like, we have people coming into our room, we're not able to understand, because there was this disconnect. And I think my husband explained to them, this is how it works. So then the next time the nurse practitioner came and said, I'm so glad you guys talked to them, because we couldn't get through them. And I think that is so important now when I look at it, that, it is assumed I completely loved the help support that we got from the hospital, from the clinicians. They respected everything, but initially it was very hard, for them to understand from the system that we came from, for them to understand, also trying to respect, because here we are, they don't know how our culture is, so they were trying to be respectful, but at the same time there was a disconnect between us and the doctors. I had met another Indian doctor who was a NICU specialist, and my husband reached out to him and I reached out to him, and then he explained a little, and there was this comfort level, so sometimes I think it's assumed that we understand the system, though I've been here for till that time by 10 years. So because we never had that situation. I was in a school of medicine. I understood the science, but I never understood the healthcare system because I wasn't educated about it. So I guess the first things are to understand how it works, how different cultures work, and I think that's a very important aspect, which is just assumed. If I can say, even though they're trying to provide the best care, but it is something that is assumed. And that I think helps a lot with my own anxieties. What is going on? What is happening with my son's condition? Who am I supposed to reach out to? And then 6 weeks later, the social worker works out where I've already figured out what I need to do. So there is a disconnect in that.
And Swati, just to follow up on that, what would been, well, maybe this happened. Did anyone ever say, Swati, I know that you haven't been on this side of the healthcare equation before. We have unique cultural elements within the U.S. healthcare system. Are there aspects of it that don't seem to be lining up for you? And if nobody asked you that question, how should a provider go about asking, and what is the right way to broach that in a manner that that also equal parts isn't based on assumption? Do we sort of ask open-ended questions that allow the discovery of it, or what would you think? And just speaking for yourself, obviously, in your experience, but how would a provider sort of try to bridge that gap?
That's a great question. Honestly, at that point, I didn't realize it myself. I didn't realize that this was an issue till, we settled down, because there was so much going on, till I was speaking to another friend, in fact, at Conquering CHD. And I said, I didn't understand. She said, I never even realized that was a problem, because we all assume that's it. And honestly, I didn't realize at that point because I was going through that. But I think one of the things, it is an open-ended question, which I think there has to be a connection where the patient is connected to the clinician. It may be the attending. I know they're busy, but there has to be someone who comes and speaks into the office. I don't have to advocate for my child. I'm depending on your expertise and your brilliance to help me. That's why I'm in the hospital. So I really feel that there has to be some connection made with the provider. So whoever is the attending has, like the first attending, the clinician made, because I know the notes get passed on. So to understand their culture, to understand their system, make that 1 hour appointment. I know they're busy, but it is the most critical connection that they need as a parent, as someone who's a healthcare provider, that, you can come and talk to us, understand our culture. It can, sometimes I know people are always bordering on the line of, being safe and being respectful, but also trying to understand when we spend that time, we understand their cultures better. We understand someone who's talking to them and really where they're coming from. I mean, talking to people, where they're coming from, and it could be 1 hour, and then notes can be passed on, and then the attending does touch base with them as what is going on. And I think that really helps, because you're lost at that point.
Yeah. Erica, I'll turn to you. I think this sort of highlights some of those tensions that exist within the system and within some of these experiences. Erica, you obviously have done a tremendous amount of work addressing mental health outcomes for our patient population, and really the expansive part of our patient population, thinking about moms and dads as well as the patients themselves. Clearly, there are going to be tensions and stressors within just being in the hospital with CHD, that, some of them are, hopefully are modifiable and we're getting better. But then we're talking here today about all these additional tensions that aren't specific to how the blood goes around relative to the congenital heart defect. Can you reflect a little bit on what the potential risks are in terms of the long-term mental health outcomes to to the patient and the family, and just how important it is that we bridge some of these gaps that have been brought up both in this session and in previous sessions, so that we even after we've appropriately patched the congenital heart defect, that we're not left with all these other elements to patch as it comes to people's mental health.
Sure, that's a big question. I think tying it back to culture, I think one of the really important things to remember is that while psychological distress is common across cultures, how psychological distress presents in terms of symptoms can look very different. And so when we think about, a mom or a patient who's experiencing anxiety or depression, one patient or mom or dad may exhibit that as somatic symptoms. So they might be exhibiting weight loss. They might not be able to sleep. They might be having stomach pain. They might have end up in the ED. Another patient is talking about thoughts and feelings, and it may be easier to identify that as depression or as anxiety. And it's our job as mental health professionals to be able to really consider the wide range in which these types of symptoms present, not make assumptions, and also not underdiagnose or overdiagnose or misdiagnose. We're really working together in a partnership with the family. I think the other thing that's important is that when we're thinking about mental health conditions, in order to make a diagnosis or even want to really address it, it has to be distressing and impairing for that patient or for that family, not for me as a mental health professional or not for a cardiologist. And so, again, when we think about the partnership, we really have to be asking, what is important to you? What is distressing for you? I can go as a mental health professional and I can ask a whole slew of questions that I direct. And I end that session or that meeting, and the patient, may say, we never actually talked about the thing that was important to me. Or, they leave with a diagnosis they didn't want, they didn't need. Maybe it fits, maybe it doesn't, but it's not actually what they were coming to see me for. And so I actually usually end most of my assessments, whether it's a developmental assessment or a mental health assessment, with, first of all, here are my impressions. What are your thoughts? What questions do you have? Always an open-ended question. And then, what did I get wrong? What doesn't sound like your child, or what didn't seem right? I think it's a lot better to ask that than to have the patient leave and say, wow, that was a waste of time. They finally got through all those barriers to get to that appointment, and then they didn't get what they needed. So those are the sorts of things that I think we think about a lot. And that's the case really with every patient and family that we work with across settings, not just cardiac, of course. But I think particularly important when we think about culture, because what I may think as a problem, the patient and family that I'm working with may not. And so thinking of an example for that, I worked with a young adult patient with a cardiac condition, and he was living at home, really not moving towards moving out. And at one point I asked him, this patient and his mom, how important is it for you that eventually down the road, you live independently? And they both looked at each other and they're like, that really doesn't matter. Like, if he wants to move out, he can. If he wants to stay, he can. And I had to check myself, because here I am working with this young adult patient thinking, one of our goals is that that patient will become more independent and, eventually get their own place. And that was not the family's goals. And if I had gone with that and focused that and really, worked through and I problem solved and identified goals and sent them home with homework, they probably wouldn't have come back to see me, because that's not what they wanted.
Erica, would you say, fair to say that addressing mental health at any point in the patient journey is of course important, but that we should be thinking about sort of at least discussing mental health, addressing mental health, asking some of these open-ended questions, both in the hospital setting as well as in the outpatient setting?
Yes.
Is that a fair statement? I
would say as many opportunities as possible, and as early as possible. And that really just helps to normalize that mental health is part of the team. We've found that if we introduce ourselves as mental health professionals too late, years into the journey, it can be stigmatizing. Why are you calling me now? Why are you suddenly showing up? And we tend to get the thank you, but I'm fine. And so by introducing ourselves from the very beginning, oftentimes, during the prenatal period if possible, or at least early in the hospitalization, we're sending the message that we're part of the team, we're an important part of the team, and that it's not reactive, it's proactive, right? And so I usually start that introduction with, we meet with everybody who's in the hospital for a period of time. And this is, making sure that they know that this is not because somebody called. We used to do that, and that did not go well. When I first started 10 years ago, that was the model, that, a nurse would call me and say, I think dad needs some help, or I think mom needs some help. I would show up. And it was very unsuccessful because, that reactive model just really doesn't work in most cases. Yeah. And so, yes, the earlier the possible. And also I would say over time as well, and across settings. So not just once, and then if the family says, no, I'm fine, we don't come back.
Thanks, Erica. Ken, I'm going to come to you next. Erica talked a little bit about that transition into adulthood. I can think of, I've met a lot of really amazing adults who are conquering CHD every day, and you certainly are a great example of that. And we're talking a little bit about culture today, and so many of our patients and families, the vast majority, come to us within the culture of pediatric care. Pediatric hospitals, pediatric clinics, balloons and Winnie the Pooh and the like. But obviously, through the great success of sort of the last several decades, we have these thriving, healthy adults who maybe aren't quite as interested in Winnie the Pooh as they used to be. Can you talk a little bit about that cultural transition that goes from pediatric care to adult care, and why that is so important, and why we need to talk about it, quite frankly?
Yes, for sure. Thank you for that. So again, my name is Ken Woodhouse. I'm from Chicago. I currently live in Chicago, and I had my second open heart surgery in 2014. And there's a long backstory that I won't get into, but like a lot of folks in my age demographic, I'm about to be 40. I fell out of care for over a decade when I was younger. I had my first surgery as a baby, and I thought I was fixed. I was very fortunate that I was healthy through most of my young adulthood, but as I went away to, after high school, as I went away to college, took a little more control of my own healthcare, I assumed I was fixed. I never had any issues growing up, so fell out of care. Fast forward to the age of 30, following a bike accident, literally fell back into care, fell off my bike and went to the hospital in an ambulance. Very fortunately, I think in some ways that accident probably saved my life, because I discovered I had an aneurysm in my pulmonary artery. Ended up having my second open heart surgery in 2014 in a Chicago setting with both really great pediatric and adult care. My experience, though, kind of in the pediatric setting and looking at it as a product of culture, just a few months after that surgery, and I was very fortunate that it went well. I recovered quickly. I was back to work in about 7 or 8 weeks. But I had a really great opportunity for a new job in a different city. And I wanted to take the job, but I knew there was a congenital heart program in the new city, but I wasn't too familiar with it. And I almost turned down a really great job opportunity, just knowing what I had gone through. I was doing well, but still feeling really vulnerable. So I was like, was I ready to go to a new city, reestablish care, like make sure I didn't fall out of care again, because I wasn't going to let that happen. So talked to some folks who were familiar with the program in the new city, and they said, it was all great. So took the job opportunity, moved to the new city. But then sort of I experienced not quite a roadblock, but a couple hurdles, because the new city that I was in, the entire program was at a children's hospital. So unlike Chicago, where they had both solid programs in the pediatric setting and the adult setting, this was all combined into the same space. And I didn't mind the Winnie Pooh wallpaper. Like, that was exciting. It's relaxing, even as an adult. But just some basic hurdles. So as I'm getting settled into a new city where I know very few people, getting settled into a new job where I know very few people, I call to make the appointment and explain who I am, want to establish care. And I get the main receptionist, and they ask for my date of birth. And they say, oh, this is a children's hospital. And I say, yes, but here's why I'm calling. They said, so you're the parent? I said, but no. So we got through that step, and then I get my appointment, and I go in for my first visit to established care. And I'm sitting in the exam room, and the nurse comes in, and as she's walking in, she's reading my chart, and she glances up at me. She looks back down at the chart, glances up at me, and she says, "Oh, you're the patient." Presumably confirming my date of birth, because they don't see a lot of adults in this setting. So it was a little bit jarring being in an entirely new city, a new job environment, and then kind of having this roadblock. The next appointment I had there, I had just a routine cath procedure, and as I was getting ready again in the prep room, the nurse comes in to get me prepared, and she says, "Oh, hold on a minute. I have to go into the storage room. We don't have a lot of gowns your size." Now, I am a 6'2" man, but it was, I mean, in the moment, it was a little bit comical because, again, it's a child setting, but it was also a little bit disorienting because I've heard really good things about this program. And in truth, like once I got through those initial hurdles, I had fantastic care, but it was getting kind of that cultural thing and a recognition for those who don't see adults all the time in this pediatric setting that, yeah, just because I was born in 1981, I'm not automatically calling on behalf of my child. So that was a little bit disorienting.
Yeah, absolutely. And I think, as a lot of today's sessions have alluded to, and certainly prior discussions, so much of what we do is based on trust, and your trust in the healthcare system, to use your example, Ken, the trust that the colleagues have in each other, and and we have to, I think, recognize that some of these moments are potential real cracks in that trust, and there are vulnerabilities in that, and I think some of those vulnerabilities lead to actual changes in the ultimate outcomes in some instances. And so, it is not just about sort of getting the right decor, but ensuring that patients and families can feel heard, seen, recognized, and with that, they can trust in the system. We can trust in their partnership. It is, I think, really crucial. Ken, I'll pivot from you and go to another great Chicagoan, Andrew, who's on the panel. Andrew, you have particularly, I think, unique expertise as it comes to the cultural elements of English as a second language within the hospital setting, and how, here again, not getting that right can be a huge vulnerability in delivering optimal care. And can you sort of, can you reflect a little bit on that, and sort of how those cultural elements may have profound impacts on the outcomes that we're aiming for? Did we lose Andrew? We might have lost Andrew. We'll come back to him. I'm guessing that he's coming back. I saw him there a second ago. We'll come back to Andrew. Oh, are you there, Andrew?
Sí. Sí. Estoy aquí. ¿Mejor sonido?
There you are. The platform is yours.
Estoy para compartir mis experiencias sobre los aspectos culturales y las barreras lingüísticas en el cuidado de nuestros pacientes, especialmente nuestros pacientes que no hablan inglés, y que es el idioma más importante y más común en este país, y el impacto que tiene en el exceso de atención sanitaria, así como las limitaciones para dar la mejor atención posible a nuestros pacientes. I'll take a step back and just imagine if you signed up for this conference for 3 days with a lot of passion and didn't have any clue as to what I just said. You had to continue on thinking that maybe you're going to get something out of it. You want to share your thoughts, but you can't speak the language. You can't understand the language. You can't read the language. Well, that is what's happening in a lot of our patient stories. And the health inequities and disparities is only becoming increasingly greater because we cannot communicate effectively with those patients. There's multiple linguistic and cultural challenges in all of these cases, and direct and indirect relationships to health disparities occurs. There's multiple studies out there that have demonstrated the importance of language concordance, whether it be with a bilingual provider or with trained interpreters. I had an example just 2 nights ago. I walked into a patient's room in the evening. I had just come on shift and it was a fresh post-op patient on a ventilator. The father was in the corner on the phone, so I waved and didn't want to interfere with his conversation. And I was evaluating the patient. I was checking out the ventilator, and his conversation to whoever he was talking to was that everybody keeps coming in the room and nobody talks to me. I have no idea what's going on. The language was in Spanish. So once he hung up, I introduced myself and I explained, how well things were going and how pleased I was with the cardiac performance. And the change in this gentleman's eyes and the comfort that came out is really incredible. The fear that he has, the anxiety that is exhibited in his facial expression disappears from a simple hello, from a simple sit-down conversation in their language. I don't think that we could ever understand the true impact that speaking a different language and having the same tongue as that patient and that family has. We all know that pediatric cardiology really has complex issues that we're talking about, highly emotional issues, and to share that information through an interpreter or through another language, so much is missed. We just talked about the mental health aspects and the difficulties all of our patients have in terms of their psychosocial situation. Compound that with a different language, it's immense. I wish I had an answer of how we could improve it, but I think we need to start somewhere. Each individual center, I think we can all do better at creating culturally sensitive websites. We can all do better in training our frontline providers, the people that answer the phone that have several language capabilities, so that access to those appointments, to their healthcare, or to simple questions can be answered. What's, I think, even more important is how can we encourage and promote the Latinx and other English language learners to be part of symposiums such as this? How can their voice be at the national level and in advocacy? Throughout the years within this organization, as well as many other organizations I'm a part of, there is very, very few voices representing the true culture of this United States, let alone other countries. I think it would be a really interesting task and empowerment of this organization to really tackle that and bring that voice to the table as well, in multiple languages and multiple cultures.
Thank you, Andrew. It's yeah, here. I mean, I think you are spot on, and just because the challenges are significant and just because the answers aren't readily available, ignoring them is at the peril of our patients and families, and saying that it's too hard to fix is just not the right answer. And I think so much about just rounding in the hospital and the nature of rounding with a family where English is the second language. And do you have an interpreter? Do you not have an interpreter? If there is an interpreter, do you go at the pace that the interpreter can provide meaningful sort of translation of what is being said. How do you incorporate that? You promise to come back, but the promise of coming back, sure, that hopefully that's delivered upon, but that's another 4 or 5 hours that a family has to wait for critical information, and that we have to wait for their unique insight. And so I don't know if you have thoughts around that. And you said already that there isn't one answer, but I would imagine you would agree that even though the answers aren't readily available, that is no excuse to sort of just sit and exist as we currently are.
I agree 200%. I am fortunate that I am able to communicate in Spanish. And when I use a Spanish interpreter, I sometimes am more than appalled at the answers and the way it's interpreted. The change that some simple words can do, and the responses that are interpreted from the families. Other people aren't going to catch that, obviously. And when I'm using interpreters in other language, I don't have that opportunity to know. In the current era, a lot of interpretation is done on the phone or through a Skype app. And so Spanish, Italian, many languages are with your hands. They're with your eyes. You miss so much of that through electronics as through this venue. So much is lost. And, I can't see our audience right now. I don't know how many of our audience are actually Spanish speakers. What Latinx population do we have? What Arabic population do we have? We don't know. I think it's highly, highly important that we do everything we can to have, number one, an in-person interpreter, have access to 24/7 interpreters. I empower the parents at any time to point to the device in their room so that they can have real-time interpretation when I'm not present, and I certainly volunteer my services all the time. But it's incredible how even in a large city, the number of nurses that do not speak Spanish. I can only count 2 or 3 in our entire unit. There's a growing number of physicians, which I think is great, but if you look at all of healthcare providers, not having a second language is really a huge, huge barrier. Not to discount the other cultural sensitivities that other cultures bring in. One thing that I had the good fortune of witnessing was the transformation of the Hmong culture in Minnesota when I trained. And the Hmong culture had a lot of fear of the medical system. Their trust was in their medical shaman. And so we had to partner with their shaman. And their shaman would come to the bedside. Their shaman would come to the medical conferences. And we would relay the information of what we think is medically necessary to the shaman. And they would do oftentimes rituals that are difficult to digest in the Western culture. But we adapted to it for the care of patients. And those included fire in the hospital. Those included roosters in the hospital. We did everything we could to appreciate their culture, but to have a blended culture to try to improve care and partner with them.
Yeah. Thanks, Andrew. Well, I am now delighted to turn to Wendy, and I'm particularly delighted that it's me turning to Wendy as the moderator and not the one answering this question for 2 reasons. One, I didn't want to answer this question when Wendy was going to ask it of me because she knows more about it than I do. And so I want to ask her, and so she can provide real, genuine insight. So, we've talked a lot in this session about some of these cultural touchstones and their value as it relates to outcomes. Certainly all of this afternoon and midday for those on the West Coast has been a discovery and a discussion around these important exposures and other variables and how they inform patient experience, certainly patient outcome. So I think we have that acknowledgement, but yet we're still sort of very short on wisdom as it relates to what are the unique risks, what are the unique combination of risks, and then how certainly do we mitigate those risks. Wendy, can you talk a little bit about where we should go as a I'm going to give you a big question, where we should go as a healthcare system, where we should go within conquering CHD and bring our advocacy work so that we're better at understanding the data, that we're better at capturing the data and translating it in more real time into practice change.
Well, thank you so much, Dr. Madsen, for asking. And I apologize for the confusion. I was on Central Time and everyone else was on Eastern Time. So got my time zones a little bit messed up. But I think I was recently intrigued as to when we became interested in race and health disparities as a nation. And the specialty of pediatric cardiology started in 1938, which is nice and long. And as a nation, we became interested in health disparities in 1980. So for 40 years, we've been working on this. And it's interesting that about 20 years ago, there was a survey done that many cardiologists didn't think health disparities existed in the United States, and only 95% thought there were health disparities in cardiology itself. So 20 years have passed since then, and I think, I had a conversation where somebody said, we've documented, we don't need any more studies to show that there are disparities. We know that. We need to move on to interventions. And I heard on the news, and back in like October, November, that there was a survey done of high school and college students in the United States. And they asked them how many of them had heard of the Holocaust. Now, I've grown up like my whole life, like there are movies, books, you're just kind of like da, 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 da. And the percentage who actually had heard of the Holocaust was stunningly low. And of that number, they asked them how many of them believed that it was actually true, that it had occurred. And it was even more shocking that many of them didn't believe it had actually happened. And I thought of that phrase that Holocaust survivors have said, that we must continue to tell our story, right? They can never forget. And I think that for me, I really have thought about this whole notion of we need to get past documenting and move on to interventions. And I would say that the same thing to us, we can never move past documenting. We can never, ever, ever stop documenting the effects of health disparities in this field. We must always tell the story of cultural differences, of what that does to our patients, and because lest they forget, right? Because how many movies have been produced on the Holocaust? How many documentaries, how many books, high school books, the whole thing. And people today around the world don't even believe it's true. And that was like a huge, massive effort of people all over the world telling their story. People going to camps, putting their feet on the ground where people die. And we have something more intangible, which is disparities, where we're just looking at patients dying too soon, right? So it's easy for us to explain that away with a myriad of other things. So we must document, we must tell that story. And I think we must collect the data. It's hard and it's tricky, right? So do you put race in a chart where that might influence the next provider's impression of that patient, or do you not, right? So it's not clear cut as to the right way to do things. But you grapple with what is right to tell the story and make sure that you have the data that you need. Because if you don't have the data, you can't tell the story. So collecting the data is vital. And you have to look at the data. I was talking with some clinicians earlier in the week who said, we have this huge data set and it never occurred to us to actually look at it to see if there were differences in our hospital. We just assumed everything was fine. And you can't assume everything is fine. Look at it and try to understand if there are differences and what might be influencing those differences. And I think moving to the next step then is, well, how can we change those differences? And if it was easy to do, we'd be like done, like 40 years, we're finished. It's a wrap. We'd be all gone home now, right? But it's not easy. It's hard, but we do the hard things because that's the most important. They're usually the most important things. So I think we talk with the patients, we talk with families, we talk with communities, we stop making assumptions, and we roll up our sleeves and we do it all over again because we'll get it wrong. We will. Preterm birth has been doing this since 1965, and we still haven't solved that problem. We've tried a myriad of things, we've gotten it wrong, but we keep trying and we keep doing it and we keep working at it. So we can't just give up because it's hard, but we keep having those conversations. So I wish I had the answer. I wish I could tell you, well, this is what we do. But we use frameworks, we test models, we borrow from other disciplines, and we learn from what they've done. And we shouldn't be afraid to try new things, even as outlandish as they might be.
Yeah, agree completely. And Wendy, so as a follow-up, you know, I'm increasingly struck by not only as we sort of look to uncover baseline difference and understand unique exposures that reveal some of those baseline differences, but you know, I find it so fascinating as we're increasingly willing to look at interventions. Let's say, you know, a new medication or a new therapy that isn't rolled out, let's say, with the primary goal of health disparities in mind or inequality or equity in mind. And, you know, let's say medication X improves the outcome of interest by 50%. And, you know, everyone celebrates, and that, you know, that medication is rolled out, and, you know, there's a parade certainly at the you know, the pharma company that has brought this medication to the world, and everyone thinks, great, 50% improvement across the board. And I think, you know, more and more, and it's not even just medication. I mean, it's local quality improvement projects at the hospital level, at the unit level, at the patient level. If we're not willing to look at the entirety of the population and ask, did everyone improve by 50%? Then, you know, it's just as bad as not asking the first question of what are the baseline differences. I imagine you would agree with that, but I'd ask you to sort of respond to that a little bit and to suggest that, you know, we have not yet even unearthed those stones as it relates to, you know, well-established therapies or medications. Does everybody respond the same way?
Well, and using your example of this new procedure or new medication that improves health, this happened in the preterm birth world, right? So progesterone, it was great. It was like, yay, we improved preterm birth. Well, then the reality is that African-American women, their insurance wasn't covering it as well as for Caucasian. There was a differential in access. The pharmacies that they could get to didn't carry that particular type of progesterone. So while that was a great improvement across the board for women who had increased risk of preterm birth, the population at greatest need of this intervention couldn't access it, right? So then that would just drive the inequity even greater, right? Because now you have one group that's accessing this great improvement in medication and this intervention, and then the group is so that just builds inequity over time. So I think if we don't look and if we don't ask the individuals, what is your experience with this? Then we just make assumptions. Oh, look, we have this great improvement across the board in our hospital. And so somebody else was telling me a story of the transition to telehealth, you know, because of COVID, you know, they weren't able to see their patients in person. And when they looked at the data, they're like, oh, good. You know, 90% of our patients, and that's not the exact percentage, but say 90% of patients were still accessing care. So they felt really good about this transition. And then, you know, however many months into it, somebody said, well, let's see what the numbers look like by race. Well, only to find out that 95% of their patients who were accessing telehealth were the majority population, and almost their entire minority population were not accessing telehealth at all. So they had lost almost their entire minority population, and it looked good on paper. They're like, oh, this is great. We're doing great with telehealth. But if they hadn't looked by race and ethnicity, they would have missed the fact that their entire minority population had dropped off the grid because of access issues or whatever barriers that were keeping them from doing telehealth. So if we don't look and we don't ask and we're not inquisitive, then we often end up with disparities right under our very noses that we don't understand, that we don't see. And then when we do see them, we don't ask the right questions.
As the panelists have been providing their tremendous wisdom, we've had a few comments in the Q&A Chris Perez brought a site that I have to admit, Chris, I'm not familiar with, called Cultural Vision, which allows you to select different religions, cultures, and see some of their views on healthcare systems. I certainly plan to look into that. That sounds super interesting, obviously. I mean, I think sort of ready-made resources, we all carry around the greatest source of information at our fingertips in our phones that we've ever had. And so, you know, using that for good, wouldn't that be a novel concept? Dr. Lopez chimed in, obviously one of the experts in our field as it relates to this subject matter, talking about visibility and representation and some of the concrete steps that we can take as healthcare providers, as healthcare systems, and certainly as, you know, those of us collected here today who care so much about congenital heart disease, what we can do to make some of these initial changes. I want to go back to the panelists. As I know we're coming to a close. If there were, you know, sort of any additional comments, I'll open it up to the group of you, just reflecting on what you've heard here in this session or earlier today, or you know, we try to bring out a few of the cultural elements brought into our healthcare systems, but we certainly didn't touch on all. We didn't touch on sort of as much rural versus urban and how that may inform cultural differences. We didn't touch on LGBTQ issues and how that relates to cultural and potential gaps in meaningful discussion and care delivery. And so I just wanted to turn it over to the panel in the last 3 to 5 minutes.
Just one thing I like to say is talking about culture, and Dr. Vobergen. I'm sorry, I'm trampling on your last name very terribly, on a panel about culture. That was really great. So sorry about that, but made really good points about understanding different cultural differences and language, and I think a lot of people fail to understand that all Blacks are not the same, and that there are cultures within the Black community. And so when you're interacting with a patient of African descent, not to make assumptions about that patient, and that all the African-American culture is a culture, the Caribbean culture is a culture, not, you know, so just again, reinforcing that every person who sits in front of you represents a culture, and that it takes time and effort to understand that culture. And as much as you might assume that you know a lot about that culture, it's best to ask questions as opposed to making assumptions, even about groups that we think we know so much about.
That's a great point, Dr. Namhat. I'm just going to piggyback on that and just say that, you know, one of the things that Dr. Andrews said, that understanding the language and making that connection for a patient for a parent is stressful in that stressful point, and making that connection through the language is a big thing. To coming back to what you asked me before, Dr. Madsen, about, so how do you think a cultural adjustment can be made with doctors? I think language and having a doctor who can connect to them. Like there was Dr. Lumba who we could often ask questions, or there was a fellow that I could connect to and ask questions, which made it a little bit easier as we went through the process with Kanan. So one of the things is having someone who can connect to the patient family and understand, like Erica said, what their needs are and what their goals are as compared to what the provider's goals are, apart from just providing the care.
So I have a question for the panel. I think we're talking a lot about you have to ask. So how do you ask? What's one really good way to ask that question? Because I think that's where a lot of folks struggle, right? Yeah, I want to ask, but like, I don't know how to ask that question, or I don't know, the best way to do it, or how to word it, or what if I offend the family? So that would be a question for the panel.
I think care conferences help a lot. Getting to know the family a bit is very helpful, because we found that very essential in asking the questions. And essentially the social worker and the nurse practitioners who made the connection, some of the doctors who we stayed long enough to make connections with them, but some of them who would stay back and come back to us after the rounds because they found that there was something that we didn't feel completely satisfied. And those are the doctors that they really care for your child. And that is the most important thing, that as a parent who needs to know that as much as I care for my son, you're also caring for them. So when the doctor came after his rounds, after 3-4 hours, and then said, is there anything that I can answer that hasn't been done for you? Is there anything that I can do? And that's when I was like, oh, this is what I don't understand. Can you help me understand? Or sometimes, like Dr. Andrew said, language makes so much of a difference, or just that question that he asked. I can imagine as a parent sitting there that someone said that, I'm so relieved. Making that connection does make a difference. So asking the right questions is coming back to that point, that making that connection with the patient's family. They are your ultimate goal to care for them. So making that connection, it's not just asking the question, but making it a conversation between the two of us to improve patient outcomes together.
Andrew, I'll give you the last word as we close this session, and thanks so much to the panelists. I think you've been referenced a few times, and I think your delivery earlier really hit home a central point. And so I want to say thanks to all the panelists, and Andrew, I'll give you the last word, and then we'll transition back to Rebecca.
I would just comment that all this discussion needs to be done quickly and early in the care in order to really bring buy-in from the families. To wait for a care conference might be too late. You need to, on your first encounter. So what is your primary language? What language do you want to converse in? What language do you read in? Where are you from? Where is this? What nationality is your name? Even if it's a Caucasian family, where does this name come from? Where are your origins? But also we also be conscious of sexual and gender identities. So how do you want to be referred to? And both for the child as well as for the parents. If there is a parent that is of the LGBTQ community and you are ignoring those issues or sidestepping, you are not going to be able to really make an impact on that child's care, because the parents are going to tune out or they're going to go elsewhere. So having visibility and open arms and an understanding of all walks of life, I think, is incredibly important for all aspects of the child's journey through their hospital situation and their care throughout their life.
Thanks again, everyone. Rebecca, I believe we'll turn it back to you at this point.
Thank you all so very much. I think I can speak for all of us at Concord